we'll do that on the 9th. 7:30 should still be fine as long as that's okay with you. And then on the 16th, we'll do 7:30 as well. Okay, great. Yeah, you're welcome. Good. Good, good, good. So, getting right into it, last time we met was last Wednesday, so we had a little bit of a break, and so I wanted to kind of refresh some of the things that we covered in pathology already before we go on and learn new things. Let's make sure that we're really getting all the knowledge possible. So we have a few questions here just to quickly review some of the topics that we talked about. So the first question, what is the Gone complex? Mm-hmm. 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 Latent, basically. Mm-hmm. Mm-hmm. Great. So you're very, very close. Where you're 100% right that it has to do with tuberculosis. However, the Gone complex is going to be for our primary tuberculosis. And so in primary, where do we see the lesion? In the apex or in the middle? For our primary tuberculosis, when we have the first episode of tuberculosis, in the middle, right? Yeah. So the Gone complex we'll see, somewhere on the outside, but it should be in the middle lobe. And then, the body fights tuberculosis. The tuberculosis kind of goes latent. And then when we get our secondary tuberculosis, it's exactly what you described. We get a secondary reactivation in the apex where there's lots of oxygen tension, where tuberculosis loves oxygen tension. And so that's where we would see secondary tuberculosis coming back. Okay, so Gone complex is always just describing this first primary tuberculosis. It's something that we see on x-ray. So when you do an x-ray of someone with primary tuberculosis, you really see two things. Number one is this Gone complex, where it's this nodule in the middle lung field. And the second thing you see is at the hyla. The hyla is where the blood vessels all enter the lung, and it's also where our lymph nodes are. So the second thing you'll see is at the hyla of the lungs, or the hilum of the lungs, it will be swollen. It will be enlarged. Those lymph nodes will be full of tuberculosis bacteria bug, right? And so those lymph nodes will be swollen, and you should be able to see that on x-ray too. So primary tuberculosis, we look for these two things: swollen lymph nodes at the hilum and a Gone complex in the middle field. Secondary, we see it at the apex. When it comes back, it goes right to the top. Okay. Yep, no problem. That's good. That's why we're doing this. Very good. Okay, good. So next question here. What is the Reed index? Mm-hmm. Mm-hmm. Excellent. Yes. So what you're saying, I'm just going to rephrase it because I totally understand, and I think if you saw it in a question, you would know what to pick, right? So I'm just going to rephrase it. So the Reed index would be the submucosal glands, whatever the size of that is compared to the whole wall of the bronchi, right? So that's our Reed index. And what pathology or what disease is this important for, right? We say a Reed index greater than 0.4 is indicative of what disorder? Yes, excellent. So these patients with chronic bronchitis, they're coughing up lots of sputum. We said that's really the big part of what they describe with these patients. Where are they getting all this sputum? Well, those submucosal glands are much larger now. That's what's giving us this Reed index, is because those submucosal glands are so large. Because we have these huge glands, they're just churning out all of this extra mucus. And so this is the mucus that those patients are coughing up. Excellent, nailed it, very good. So next, what are our two major types of emphysema? Excellent. Panacenar and, yep. Did I spell that right? Not really. It's Panacenar. Great. And our centroacinar. I think I heard you say it, right? Centroacinar. Good. Okay, good. So, no, it's okay. It's good. It gives it a little flavor. It's nice. So with our panacinar, we'll start with our centroacinar. What are we associating this with? Patients that smoking. Very good. Very good. So patients that smoke, they tend to get centroacinar emphysema, whereas the panacinar is associated with wonderful. Alpha-1 anti, I'm not even going to write it because it's down here, but yes, this antitrypsin deficiency. These patients, they have activation of an enzyme that just globally is breaking down their acini, or the walls of the acini, I should say, okay? Giving them those floppy lungs. This is an obstructive condition. They're trapping air. They're getting that larger residual volume, larger FRC, larger total lung capacity, et cetera, et cetera. I can go on and on, right? But I'm not going to bore you with that right now. Instead, I'm going to ask you one more question, which is, what should we be concerned about in patients with that alpha-1 antitrypsin deficiency? So emphysema, right? That's for sure. We're worried about emphysema, but what other organ system should we also be worried about? Excellent. Yes. The liver. The liver takes a lot of damage in alpha-1 antitrypsin deficiency, and these patients end up with cirrhosis, liver failure, et cetera, et cetera. These patients have a hard time, metabolizing food and hemoglobin, all that stuff, because their liver gets damaged from basically storing up all that enzyme that's not going to the lungs. Okay? Excellent. Very good. Okay, so I think we are warmed up and ready. We can start talking about our next pathology here. Very high yield for step 1. They love asking about this particular one, sarcoidosis. So sarcoidosis, we're not really sure what causes it, but it involves many systems of the body, okay? And so what we see is throughout these different systems of the body, the lungs, the GI tract, even the brain, we see these non-caseating granulomas. Okay, so what do we mean by a non-caseating granuloma? What is this word non-caseating and caseating? What does that refer to? It's okay if you're not sure. So a granuloma, we'll start here. A granuloma, what is a granuloma? When we say that, what comes to your mind? Excellent. Yes, I would describe it the exact same way. A group of cells coming together to fight something off, right? So we have granulomas to fight off bacteria like tuberculosis. We talked about some granulomas there. But essentially, like you said, it's a group of cells that are coming together to fight something. And so here's our granuloma. They're typically round shape, and we're going to see a lot of cells inside. Now, in the case of tuberculosis, what we have is a caseating granuloma, okay? And this word caseating, it actually means cheese. And so if you look at a granuloma of tuberculosis, what you see is it actually looks like cheese. Everything inside is completely broken down. It's like a cheesy mess. Imagine some cottage cheese. Really just nasty, cheesy stuff comes out because everything inside has been completely liquidated, destroyed, just completely obliterated. There's really nothing inside left in terms of cellular material, okay? So that would be a caseating granuloma. However, in sarcoidosis, what we see is non-caseating granulomas. And if we look here at this picture, you can almost see this round structure, right? We can see a little bit of a lining. And inside of the structure, rather than seeing everything completely destroyed, dissolved, just a cheese-like material, instead, what we see is there are cells in here. We can see plenty of little blue cells. We even see large cells with multiple nuclei inside, okay? And so this is going to be a granuloma where everything, instead of getting destroyed inside, we just sort of have an inflammatory activation going on. And so all of these cells that you see here are all going to be macrophages. Okay. When macrophages get involved in granulomas, they coalesce together to form these giant macrophage cells where we see multiple nuclei inside of a single cell. Okay? And whenever you see this, think of a macrophage. Okay? So that is going to be very typical for sarcoidosis, non-caseating granulomas. Where do we see these? We can see them in the lungs, we can see them in the eyes, we can see them in the skin, we can see them in the central nervous system. There's a very specific example. I think we'll do a question later that talks about it, but there's some places in the central nervous system we can get granulomas. In terms of the patient population, this is typically described in African American females, and in my experience, when you get a question on this, whether it's on your exam, in UWorld, in any of these question banks, they are always going to say African American female. So much so that when I was in medical school, this was the joke, that the question starts like this: African American female presents, and then you stop reading there and select sarcoidosis, right? So that's not actually the case. You need to read the rest of the question, but in general, they will always tell you it's an African American female. Okay. Another thing that is very specific for sarcoidosis is seeing hilar lymphadenopathy. We talked about the hyla of the lungs. So here's one lung, here's our second lung, and here is where the blood supply comes into the lung. All of the air coming into the lung from the trachea, it's all going to enter right here at the hyla. Okay? So right where this structure enters the lung, we call that the hilum. Having swollen lymph nodes on both sides is very typical for this condition. Bilateral hilar lymphadenopathy seen on chest x-ray. This is one of the, really just like a 5-star point in terms of diagnosing this. If you ever see these 3 words together in a question stem, the answer is sarcoidosis. That is how high yield this particular point is. If you ever see bilateral hilar lymphadenopathy, please choose sarcoidosis because not a lot of other things cause that. Okay? If we have a patient with tuberculosis, you will see hilar lymphadenopathy, but it won't be bilateral. It will be on one side or the other, depending on where the infection is. Okay? So bilateral hilar lymphadenopathy, this is a 5-star point because they often describe that. All right? So another thing that I want you to keep in mind is that patients with sarcoidosis, one of the things that you're going to test for in the blood is elevation in that ACE, which is the angiotensin converting enzyme. This is the enzyme that's important for, the angiotensin 2, aldosterone, the RAS system. This is that first enzyme that we talk about, converting angiotensinogen to angiotensin 1. That is ACE, and for whatever reason in sarcoidosis, we see high elevations in angiotensin converting enzyme. Okay, so please put a big star by this because that's going to be your way of diagnosing it. Or they can give you all of these things, right? They can describe these non-caseating granulomas. They'll tell you it's an African American female. They'll tell you this, and then all of your answer choices will be A, elevation in troponin, B, elevation in something something, C, elevation in something something, and then D, elevation in ACE. And then you'll need to select elevation in ACE. It doesn't make sense. What does this have to do with these granulomas? Who knows? Don't worry about it. This is going to be your answer. Okay? Great. And the last thing that you will be asked about is this elevation in calcium that you see in patients with sarcoidosis. Why? So, one little thing about macrophages that is not really mentioned too often and is pretty important when they all get together is that macrophages have a certain enzyme called 1-alpha hydroxylase. Okay, macrophages, they all have it, and when they get together, they make a lot of it. Who cares? What is this 1-alpha hydroxylase important for? This particular enzyme should ring a bell for you because when you talk about calcium levels, we talk about one particular hormone playing a big role in calcium levels. What hormone is that? Or vitamin, I should say. Vitamin D. Yeah, very good. So vitamin D starts off as 25 vitamin D. It goes to the kidney, and the kidney has an enzyme called 1-alpha hydroxylase, which converts it to 125 vitamin D. And 125 vitamin D is going to go on to increase your calcium level, and it's going to increase your phosphate levels. Okay, great. So this enzyme, 1-alpha hydroxylase, essentially is going to be the enzyme that converts your inactive vitamin D to your active vitamin D. That's what this enzyme is for. Now, what I just told you a moment ago is that macrophages have this enzyme inside of it. And when these macrophages get together, they start secreting this enzyme like wild. So what's going to end up happening is you're going to have a huge elevation in your level of vitamin D. Okay, huge elevation in vitamin D equals a huge elevation in calcium. Okay, so patients with sarcoidosis, what do we look for in labs? We test for angiotensin converting enzyme, and we want to look for those calcium levels and make sure they're not too high. Okay? Okay, so in the spirit of learning and teach back, could you do me the honor of explaining to me why patients with sarcoidosis have a high calcium level? Why is that? Yep. Hydroxylase, yep. Mm-hmm. Mm-hmm. Excellent. Very, very good. Yes. Yes, that is the entire process. This is another one of those points that is going to get you really nice bonus points on step one. Because the truth is, yes, in sarcoidosis, we have elevated calcium because of these non-caseating granulomas. But what you're going to find is, as we talk about some other disorders that have these non-caseating granulomas, they will have the elevation in calcium as well. Why? Anytime you have these groups of macrophages, they're going to do the same thing. Okay? So, very good. Excellent. What else can we say about this? I think that's enough, right? I think that's enough. That's all they can really ask you about, I think, for this particular disorder. So we're going to move on. Yep, so again, pointing out that bilateral hilar lymphadenopathy. I used to have 5 stars here. You remember that, so you know it's important. All right, so now moving on to some of our pulmonary events. This is bringing us more into just from pathology. We can talk about a little bit of pathophysiology and tie in a little cardiology too, just for fun. So, pulmonary thromboembolism. A thromboembolism, we can kind of break down this word. Emboli is anything that travels through the blood. You can have fat emboli, air emboli, thromboemboli. Really, anything traveling through the blood is going to be considered an emboli. A thromboemboli would be a thrombus or a clot that is traveling through the blood supply. Okay, very straightforward, very simple. A large emboli would cause a sudden death. We have the pulmonary artery leaving the right atrium. Here's our pulmonary artery here. Here's our right ventricle. Okay, I know I said right atrium. That was very wrong, right? Here's our right atrium. Bless you. So here's our right atrium. There's our tricuspid valve. Here's our right ventricle. Here's our pulmonary valve. So a large thromboembolism that goes into our right atrium through the right ventricle and then gets stuck here. We call this a saddle embolism because you can kind of imagine 2 feet in a saddle here. And this emboli is going to completely obstruct the blood supply going from the right heart to the lungs. Okay, so now we have 0 blood going from the right heart to the lungs. Your patient's going to die. Okay. However, for small emboli, these cause just a transient chest pain, cough due to hemorrhage in the lung, shortness of breath, fever, coughing up blood due to that infarcted area. We can look at what that might look like. So you can imagine sort of, the blood supply to the lung kind of coming here, going from an artery to an arterial. And as we get to this arterial is where we have the obstruction. We have a little bit of a clot coming here, into these smaller and smaller vessels. And then finally, boom, it obstructs at this point. And then we get something called a wedge infarct. Wedge, W-E-D-J-E, wedge infarct. And that just means a basically triangular shaped infarct. That just means we have that small area of lung tissue lost its blood supply. Okay, so this would be a pulmonary embolism, just like you've learned in the past, typically coming from one of those deep venous thrombi in the legs and then migrating through the venous system, through the inferior vena cava, through the right atrium, through the right ventricle, and then into the pulmonary artery, into the arterioles, and then getting obstructed here in the lung. So a patient with this type of pulmonary emboli, this is not a life-threatening embolus. I think we could agree. There's plenty of other lung tissue that can make up for this small infarct. However, when your patient presents, they are going to be very uncomfortable. They're going to feel short of breath. They're going to report a sharp pain in their chest. And so these are the things that you want to look out for with your patient. Tachycardia. Those are all the typical symptoms of a pulmonary embolus. Okay, any questions on this? No? Okay, great. So pulmonary hypertension is whenever we start to get an elevated pressure in the pulmonary supply. And so when we think about what would cause a high pressure in the pulmonary supply, there's some very specific causes. So anything like COPD, where you're having destruction of some of your alveoli, that's less places for blood to go. If we have less places for blood to go, the pressure is going to increase, right? Because when we used to have 10 places for the blood to go, now that we've had COPD, we've lost about, 6 of them. And now blood can only go into 2 spots. And so blood is going to be kind of fighting to get into those spots. So pressure is going to increase. Interstitial lung diseases, we can get obstruction of the arteries there. And so that's going to increase pressure. Congenital or acquired heart disease. When we have something like a VSD between our ventricles, here's our left ventricle, here's our right ventricle. Before our Eisenmenger's phenomenon, blood is going to be passing from the left ventricle to the right ventricle, okay? And that extra blood is going to be pumped to the lungs. That is going to increase pressure because now we have more actual blood supply going through these areas. Recurrent thromboemboli. If we have a thrombus, like we mentioned on the last slide, but it happens again and again and again, here, same thing. We're losing places for blood to go, and so pressure is going to increase. Autoimmune disease, obstructive sleep apnea. These are some other common causes of pulmonary hypertension. Okay. All right. So while we're, since we're mentioning these acquired heart diseases, what is the most common congenital heart defect? I'll give you some choices. I'm going to give you A, B, C, and D. I'm going to say ASD. I'm going to say patent ductus arteriosus. I'm going to say a VSD. And I'm going to say something else that's wrong. Okay, wrong answer. I can't think of anything else right now. Okay, so of all of these, which one is the most common congenital heart defect? So, ASD is very common. It is not our most common. Okay, but since you said ASD, I'd like to know of all of our ASDs, what is more common, the ostium primum or ostium secundum? Which one is the more common of the ASDs? I'm only asking because you brought it up. Okay, I was ready to keep moving on. Excellent. Yes, the ostium secundum. This is AKA our foramen ovale, right? And so in normal physiology, in our growing fetus, that is an important thing to stay open because that's going to allow oxygenated blood coming from the mother to pass from the right heart to the left heart and be pumped to the entire system. So during development, it's normal to have this open. If it stays open after birth, we call it that ostium secundum, and that is the secundum type ASD. That one's more common. Primum is more associated with Down syndrome. Okay, great. But this is not our right answer. This is not the most common congenital heart defect. So which one is our most common? I'm going to take a, yes, VSD. Very good. That ventricular, sorry, go ahead. Yeah. Yeah. Okay. That's okay. You know what? Step one's going to do the same thing to you. That's why I'm torturing you now, because it's better to get tortured now and succeed later than me not torture you at all. So VSD is our most common congenital heart defect. Very good. Okay. So this patients with VSD can be the ones presenting with your pulmonary hypertension. And so that brings us back here. Clinically, what do we see with pulmonary hypertension? First, we're going to look for just shortness of breath, fatigue, angina, as that right heart is trying to pump against this higher pressure in the pulmonary system. We can start to present with angina. Okay. However, as our patients are having that right heart, we start to have right heart failure, essentially. We start to see respiratory distress, cyanosis, right ventricular hypertrophy. Again, the right heart is pumping into this high pressure system, so the muscle is going to get higher. Death in these patients is going to be from cor pulmonale. Okay, you asked me about cor pulmonale, I think during our first lecture, I'll never forget it, and so I like to point it out. Our cor pulmonale is right heart failure due to pulmonary hypertension. Okay, right heart failure due to pulmonary hypertension. The left side of the heart is completely fine in this case, just pumping along. However, because of this elevated pressure in the pulmonary system, what we see is that the right heart is having to work twice as hard, 3 times as hard, 4 times as hard, and ultimately these patients get very, very sick. Death could be because of a superimposed thromboembolism, pneumonia, as we have, parts of the lung are not getting enough perfusion. Immune cells cannot get there to fight bacteria. These patients can develop very bad pneumonia. And obviously, right ventricular hypertrophy is a big part of that picture. Okay? What questions do you have about pulmonary hypertension? Does this make sense, or is there anything that that's not totally clear? Makes sense? Okay, good. Good. Okay. So in that case, we can move on from our pulmonary events into talking about lung cancer. This is an area where they will ask tons and tons of questions, as I'm sure you know. They love asking about lung cancer, okay? And so before we get into talking about our bronchogenic, squamous, small cell mesothelioma, what is wrong with this CT scan that I just noticed right now? What is something that's not particularly right about it? So I guess first, describe what you're seeing on this CT scan. Is this a healthy patient? Does this patient have lung cancer? What do you think? Mm-hmm. 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 This thing right here? Excellent. Mm-hmm. Mm-hmm. Basically, like you're talking about like the thickenings of the vessels, essentially. Yes. Yeah. Good. Yeah. So that is definitely something that we would want to look into in a patient like this. So, but this mass is something that we would be very concerned about. Now, the reason I said that there's something wrong with this picture is what do we notice here on the top, or here on the top, which should be on the bottom? So this is going to be the scapula, and the spine is at the top. It should be on the bottom. I think I put this upside down, so I apologize for that. But yes, otherwise you're absolutely right. This is something that we would be concerned about. Okay, great. And this is another, I guess, lesson that we can take from this slide is that, your options, they could have given you this upside down, possibly, right? Even though a patient would never be upside down in a CT scanner, especially one with lung cancer. They could give this to you and say, okay, where is the tumor? Right lung, left lung, right big toe, right? And then you would probably say, oh, okay, this looks like it's in the left lung. But because the CT scan is upside down, it'd actually be the right. I don't think they would ever do that, but you always want to be on your game, right? All right, so we're going to hop into bronchogenic carcinoma here. This is the most common cancer of the lung. Accounts for 90 to 95% of tumors of the lung. So this is an important point. If you're ever asked about what's the most common lung cancer, it's going to be our bronchogenic carcinoma. For all the time that we sit here talking about small cell and squamous and all these other fancy lung tumors, bronchogenic carcinoma is actually going to be the carcinoma that we would see the most when we're taking care of patients. It's insidious, meaning it's slow growing, aggressive. And of all of these cancers, it's very aggressive. Peak incidence is going to be between the ages of 50 and 60. Our small cell carcinoma, squamous cell. Squamous cell we have to talk about because there's a lot of different aspects. It's been very well studied. So there's a lot of different aspects they can ask you about. Okay, so first of all, this has a strong association with cigarette smoking. They're talking about a cigarette smoker. I want you to first think of squamous cell carcinoma. This particular cancer is more common in males, and this is a central mass on X-ray. And so you can see here in this picture, what you see is here is our bronchi coming off. And you can see all of this is going to be our small cell cancer. It's a giant pathology slide of small cell cancer. And you can see this is more central, right? I think we could agree that this is towards the middle of the lung. So this would be a central mass on X-ray. In general, when we're talking about lung cancers, if the name of the cancer starts with S, it's going to be a central cancer. Okay, so our squamous and our small cell are both central masses. The way that we remember this is we write central. Okay, central mass, and I know I spelled that wrong. The S is for squamous and the S is for small cell. Okay, so that will help us remember because this is something that they do ask about. Okay, so we have growth both into the lumen of the bronchi and under the submucosa. Remember when we looked at that image of the bronchi, when we looked at read index, you can imagine the layers of the wall of the trachea and the bronchi, right? And so think about the cancer growing both vertically into the lumen where the air is supposed to be and growing south through the submucosa and towards the actual wall of the bronchi. Okay, it's kind of going to grow in both directions. TP53 is one of those cell cycle regulating proteins. And this has the highest frequency of mutations with P53 of all those tumor types. So if we deactivate P53, we start to have this very irregular and pathologic growth of cells. Okay, and so this particular mutation, while we can see this in other cancer types, has the highest frequency with squamous cell carcinoma. You're almost guaranteed to see it. Okay. And last, we have this paraneoplastic syndrome that is associated with, squamous cell carcinoma, parathyroid hormone-related peptide, PTHRP. Okay, so this is a protein that is created by these cancer cells. This protein looks like parathyroid hormone. So what would this manifest as clinically for our patients? What would we look for on lab work, for example? If we had a high level of PTH-related peptide, meaning essentially a high level of parathyroid hormone, what would we look for? What changes in electrolytes would we look for? So PTH is created by the parathyroid glands, right? Obviously, duh. But parathyroid hormone is going for calcium. Calcium, yes. And so the two hormones that are in charge of calcium levels are vitamin D and our parathyroid hormone. Vitamin D increases levels of calcium and it increases levels of phosphate. Parathyroid hormone increases levels of calcium and decreases levels of phosphate. Okay, and so that is the sort of important thing between vitamin D and parathyroid hormone. In patients with squamous cell carcinoma, they end up with this fake parathyroid hormone that works just like regular parathyroid hormone. So you should look for hypercalcemia and hypophosphatemia. Okay, and so what you were trying to say, I think, was hyperkalemia. Right. So that sounds a lot like hypercalcemia. And when I was studying for step 1, I used to get those confused like crazy. Like I would have to like, every time I would read that word, I'd have to like read it twice, like actually move my head and read it twice because I would get it confused all the time. But hypercalcemia is going to be high calcium. Hyperkalemia is going to be high potassium. Okay, great. So a little mnemonic that I made to help us remember the little things about squamous cell carcinoma is PQRS, like in the alphabet, LMNOP, QRS, TUV, right? So the Q is going to be for squamous. Okay, squamous. The R is going to be for that PTHRP. Okay. The S is for central, right? Because any of these tumors that start with an S, we know it is a centrally located tumor. And the P is for, what is the P for? This is an important one. Yes, this is for our P53 mutation. Okay, highest association with the P53 mutation is our squamous cell cancer. So P for P53, Q for squamous, PTHRP, and S for central. If you have these 4 things down about your squamous cell carcinoma, you are in a really good spot for answering questions, okay? Because these little things they will ask you about, and you know how these questions go. They don't make it straightforward where you can just easily pick the answer. They're going to describe squamous cell cancer for you. They're going to give you everything you need. They're going to say it's P53. They're going to tell you PTHRP. They're going to tell you everything. And then the options will be central, peripheral, all of these different things. And you have to try and remember, oh my God, was this one that's going to be in the middle or one that's peripheral? Here's your way of remembering this. PQRS, the Q helps you remember squamous, and then you just build everything off of there. Okay? All right. This is one that I made up. Okay, this is the good stuff right here. This is going to help you out a lot. Our adenocarcinoma, this is the tumor of females and the tumor of non-smokers. Okay, so if they tell you specifically that someone does not smoke, but they have lung cancer, start thinking about adenocarcinoma. Okay, adenocarcinoma does not start with an S, and so what does that tell us? This is going to be a peripherally located tumor with various growth patterns. This is typically going to be positive for TTF1. This is a stain that we can do on histology to basically look at our tumor. And in terms of other mutations, KRAS, this is an important one to memorize. This KRAS mutation, RAS is a protein that's associated with cell signaling. Okay, and so you remember your G proteins and your G protein coupled receptors? Right, like our GQ receptor, our GS receptor. So for example, our GS receptor, when we have something bind to it, that increases our levels of CAMP inside the cell, okay? After we increase our level of CAMP, that's going to activate certain other enzymes. One of those proteins that's going to be activated is our KRAS, okay? And so that would activate our KRAS, and ultimately it would have downstream effects. In this case, it would be increase the cell cycle. Okay, we need to start multiplying and creating more cells. So typically with our G protein coupled receptor, you need some sort of neurotransmitter or hormone to bind that receptor and start this cascade. However, with the KRAS mutation, KRAS is just going to activate without getting any signal. Okay, so CAMP is not activated, GS is not activated, we had nothing binding, but RAS is still increasing the cell cycle. Okay, and so when this cell multiplies and creates another cell, that cell is going to do the same thing. And this really pathologic cycle is going to keep going on and on and on and on until we have many, many, many cells in this tumor. Okay, and so when you talk about KRAS, it's important, right, as we're talking about all these things, to know what the heck, why am I memorizing just a bunch of letters? Let's really talk about what is happening here. And so that KRAS mutation is going to be one thing associated with adenocarcinoma. Epithelial growth factor receptor is another thing that can be mutated. I would say KRAS and EGFR are the most important ones to memorize and associated with adenocarcinoma. Memorize these two. ALK and MET, a little less high yield, but EGFR and KRAS, if you only want to memorize 2 things, memorize those 2 as possible mutations in your adenocarcinoma. Okay? Great. Our small cell carcinoma, aka oat cell carcinoma, because it kind of looks like oats. This is our most aggressive carcinoma. Heavily associated with cigarette smoking. When we take a biopsy, you can see that these tumor cells really resemble lymphocytes or small blue cells. You'll hear it described as small blue cells. And as you look at this histopathology, you can see that description is very accurate. As this particular cancer starts to divide and really get bigger, it's going to go into the bloodstream, it'll go to the liver, it'll go to the brain, it'll go to the bone. Okay, those are the three places it's most likely to go. Small cell tends to be central. It can be peripheral, but really most of the time you want to memorize central associated with small cell. Why? Boom, you got your S right there. S for central really tends to be central. Okay. So small cell carcinoma, another thing that they love asking about is this paraneoplastic syndrome again, where the tumor is creating antidiuretic hormone. Okay. So a patient with antidiuretic hormone, this is going to make the level of water in the blood increase or decrease. Antidiuretic hormone, what does it do? What would a patient like this look like? That's what I'm trying to ask you. What do you think this would happen clinically with a patient with too much antidiuretic hormone? So very similar to Cushing's syndrome, yeah. A little bit, it's similar but different, right? So it's in that picture of all of these endocrine disorders, which we're going to talk about when we come back from our break and we finish GI. We're going to talk about them. But antidiuretic hormone, just breaking down the word, antidiuresis. Diuresis means peeing. This hormone prevents peeing. Okay, so we'll just start there at the source. So if we have a patient with high levels of antidiuretic hormone, do we expect them to have a very concentrated but small amount of urine or a lot of very dilute urine? Yes, a very concentrated, small amount of urine. Because what antidiuretic hormone does is it goes to the collecting ducts of the nephron and it inserts all of these little water absorbing channels. They're called aquaporins, right? You know this. So these aquaporins will suck up all of the water that the patient was about to pee out. It'll suck the water back into the bloodstream. However, this patient is still going to be peeing out all of their salt. And so what happens is the H2O in their blood increases while the salt or the sodium is going to decrease. We have decreased levels of sodium, increased levels of water. These patients are going to have hyponatremia. Okay, patients with hyponatremia, they can, pass out, go into a coma, and so we really need to restore those sodium levels and stop them from peeing so much. Okay, so antidiuretic hormone. I want you to think of a patient that is retaining lots of water. Okay, good. For the purposes of this, in these types of questions, what they want you to know is what is the hormone that's being secreted. All right. Everything I just explained to you is getting you to start thinking about the next step. Okay. Making those connections with endocrine, making those connections with your renal section, right? And so, because that's kind of how they're going to ask questions sometimes. So it's pretty important. And so, last thing before we go on. Can I have a blank slide? Is that possible? Hold on a second. Okay, so hold on. I'm just going to make a blank slide so we can talk about our Cushing's syndrome quickly. Okay. Okay, can you see my screen? It's a white screen. Okay, good. So for Cushing's syndrome, the main offender in Cushing's syndrome is going to be increase in cortisol. Okay, so cortisol, it's coming from the adrenal gland, and its job is to increase blood glucose. It's also our stress hormone, and so it's going to activate our sympathetic nervous system. or increase the working of our sympathetic nervous system. And it's also going to decrease the activation of our immune cells. Okay, so it decreases our immunity. And last, it's going to cause breakdown of skin. Okay, so those are all of the things that we look for in our Cushing syndrome patients. And so in terms of our clinical picture, look for someone with hyperglycemia, look for someone with skin breakdown. So what they describe that as is purple striae. And what that means is essentially because of the breakdown in collagen in our skin, it starts to take on a purple color and it gets very thin. Okay, so that's the breakdown of our skin. These patients tend to get infections because of that decreased immunity. Because of the blood glucose, they tend to have a lot of obesity in their abdomen. And you'll hear also described as buffalo hump. Okay, not a very nice thing to say about someone, to be honest, that you have a hump like a buffalo. But hey, that's the medical term, okay? I didn't make it up. Buffalo hump, and what that refers to is basically right at the tip of the thoracic spine, right where the neck connects with the thorax, is going to be this accumulation of fat, basically a fat pad right there. They call that a buffalo hump. The other thing you'll see is the collection of fat in the face, giving you something called a moon face. Okay, moon facies. Okay, so that is going to be our Cushing's patient. And Cushing's is just increased cortisol, way too much cortisol. Okay, for whether it's from a tumor in the pituitary, a tumor in the adrenal gland, or just a patient who's taking too many steroids, too many corticosteroids, all of those things can produce a Cushing's syndrome. Okay, great. And obviously we'll talk about this more when we do endocrine. So tumors of the lung, a lot of these lung tumors will metastasize to the adrenal glands. If it's not going to the adrenals, think liver. If not there, think brain or bone. That's where lung tumors go. Adrenal glands, liver, brain, and bone. So our next tumor of the lung is actually not a tumor of the lung itself. It's a tumor of the pleura around the lung. And so before we get into what the text here says, I'd like you to look at this image. This is a gross pathology of someone with malignant mesothelioma. And describe to me what you see. Where do you see abnormalities? Mm-hmm. Good. Good. So the color of the pleura. Good. Good. Yes. Yes. Excellent. Yeah, very good, Natalia. So here you can see that the pleura is very thickened. It's inflamed, like you said, and the color looks a lot brighter on this side. Look at how white that is. That is not normal. And so what you're describing here and what you're seeing is a tumor, essentially, of the pleura. Our mesothelioma is just a tumor of the pleura, the lining of the lungs. That's all it is. It's a fancy name. All it means is a tumor of the pleura. That's okay. That's all right. And so this can be the visceral parietal pleura, meaning it can be the pleura that's right against the lung or the pleura that's against the chest wall. Patients who are exposed to asbestos have a higher incidence of mesothelioma. In fact, if you have a patient with mesothelioma, it's pretty safe to assume that they were exposed to asbestos at some point. Okay. What we see is pleural effusion, invasion of thoracic structures, and we can see that a bit here as you have this pleura almost invading some of the pericardium. Doesn't quite look right. Let's see where else. Maybe here we can see some invasion of other thoracic structures. Not good, okay? This is a very invasive, locally invasive tumor. And so the particular mutation that we look for is a loss of a tumor suppressor gene. That's our CDKN2A and our INK4A. CDK is another one of those cell cycle regulators. Okay, when CDK levels hit a certain point, it tells your cell that it's okay to progress to the next level of your cell cycle, or the next part of your cell cycle. That's what the CDKs are for. They regulate the cell cycle. And so that is the particular tumor, the particular mutation that we see in these tumors. Let's see. What else did I want to say here? So the last thing I want to say about malignant mesothelioma is we always talk about asbestos with mesothelioma, right? Those two are married. However, one important point. If you're someone who worked in roofing, you had exposure to asbestos, the most likely cancer for you to get because of that asbestos is bronchogenic carcinoma, not malignant mesothelioma. Okay? Patients who have exposure to asbestos are more likely to get bronchogenic carcinoma than malignant mesothelioma. But the only way to get mesothelioma is to be exposed to asbestos. Okay? And there's a lot of different ways to get bronchogenic carcinoma. So that's sort of the important point that we have to make here, is that yes, we have mesothelioma and asbestos. They're married and they live together happily. But what you need to know is that asbestos is more strongly associated with bronchogenic carcinoma than mesothelioma. Okay? Make sense? Great. So, in terms of differentiating between our mesothelioma and adenocarcinoma, this is one area that can try and trip you up. What you need to know is two basic facts. Number one, mesothelioma is going to stain positive for things that you see in keratin, right? So keratin proteins, calretinin, Wilms tumor 1. These are some of the names of the dyes that pathologists can drop and then look under the microscope and see that it stains positive. Okay. The second thing that you can look for is on electron microscopy. What we see is the microvilli in mesothelioma are long and thin. The microvilli in adenocarcinoma are short and blunted. Okay, and so these things will typically be described to you to kind of push you into one direction or the other. This will maybe be one question on your entire exam, so don't worry too much about this. Really take it at face value that it will be described for you. They'll say this patient has some tumor that came from the lung. On electron microscopy, we saw microvilli and they looked like blank. And then they'll want you to choose either adenocarcinoma or mesothelioma or squamous cell carcinoma or some other random thing. And so just know that for mesothelioma, think about a long, slender, just think about a tall, skinny guy that works on the roof, and then you'll kind of have that association with asbestos and mesothelioma, versus adenocarcinoma is more associated with non-smokers and women. So you can think of a short woman who doesn't smoke, and then that will be your association with microvilli. Okay? Great. Okay, so we have some rapid fire questions here. What causes a transudative pleural effusion? Okay, so transudate versus exudate. This is an idea that we didn't really go over too much because I wanted to go over it quickly here. When I talk about transudate and exudate, what does that make you think of? What is one more associated with versus the other? Transudate and exudate. Does that remind you of anything? If not, that's okay. Good. Yes. Yes. So it's all about the proteins. Very well said. So which has more protein, transudate or exudate? That's okay. So exudate, we're going to associate exudate with bacterial infections. Okay, so exudate, we're going to think of bacterial infection, lots and lots of protein being pumped out. We're breaking down the bacteria. We're releasing all the bacterial proteins. Whenever you have exudate in the pleura, you probably think about something like pneumonia. So let me just write bacterial infection. The other common thing is if you have a tumor, sometimes the tumor can cause some exudate there. And so those are the things we're going to associate with exudate. Transudate is going to be that low protein fluid in your pleural effusion. And so increased capillary pressure. So if you have a left heart failure where blood is backing up at that left atrium, backing up at the pulmonary vein, now blood is backing up in the capillaries of the alveoli, that's forcing fluid out of the bloodstream and into the pleural area. So increased capillary pressure, low levels of serum protein. You can think about your patients with cirrhosis of their liver. With patients with liver failure, they can't synthesize proteins. They end up getting a pleural effusion due to liver failure, essentially. Okay, great. So what causes an exudative pleural effusion? I feel like I've kind of given this one away. What causes an exudative pleural effusion? Excellent. Good. Any infection, malignancy, or one thing I forgot to mention, a pulmonary infarct. If you have death of some pulmonary tissue, all of those proteins are going to be released into the pleura, and we can have an exudative pleural effusion. So, two main causes of foul-smelling sputum that we talked about in today's class. Not people with just bad breath, okay? Leave them alone. Maybe they can't afford toothbrushes. Who knows? Okay. That's okay. So our foul-smelling sputum, we should think about bronchiectasis. Bronchiectasis. And bronchiectasis, what happens is, here's our bronchi, here's our branches of the bronchi. What happens is patients that have very thick mucus, they get a lot of occlusions of their bronchi, right? This is the airway. Air is trying to come through, air cannot. And now everything that's downstream of this is basically lacking air supply. So you're going to have bacteria growing here. You're going to have all of this debris, nasty stuff accumulating behind this plug. Okay. Eventually, this patient will be able to pass this plug and this stuff is going to escape. However, you're going to have, because they have thick mucus, you're going to have another area where you have a blockage and everything downstream becomes really nasty. And so patients you should be thinking about in this case are patients like cystic fibrosis patients, where they have very thick mucus. They tend to plug up their lungs a lot. When this happens over a long period of time, your downstream airways are going to dilate, and those downstream airways are going to become very stinky. And so in terms of foul-smelling sputum, think about bronchiectasis, and the other main cause, pulmonary-wise, could be an abscess in the lung. Okay? Very good. Chylothorax, this we mentioned before, basically just a pleural effusion of lymph tissue, right? We talked about pneumothorax, hemothorax. That was about it. Chylothorax is the last one. If you have some sort of rupture of your lymph tissue, that lymphatic fluid can start flowing out into the pleural area, giving you a chylothorax. Why is it significant? You can have some obstruction of those lymph ducts due to a intrathoracic cancer. So when you see chylothorax, think about a patient probably has some sort of cancer in their lungs, in their bronchi, in the pleura, a mesothelioma, something. They have some sort of cancer that's blocking the lymph ducts. Okay. Three most common causes of chronic cough: asthma, our postnasal drip, and gastroesophageal reflux. This one's pretty high yield because it's one that you don't really think of initially, but these patients, when they have acid coming up their esophagus, especially at night, some of that acid is going to cross over into the airway, and when they wake up in the morning, that acid's going to really inflame all of their lung tissue and give them a cough. Okay? So gastroesophageal reflux does cause cough. If you treat the GERD, if you put them on a protein pump inhibitor, a PPI, guess what? The cough is going to go away. That's the nice thing about it. Okay? Those are three most common causes. What are some examples of obstructive pulmonary diseases? Help me with this one, Natalia. Good. Chronic bronchitis, asthma. I love it. Yep. Emphysema. Yeah, great. Those are all obstructive. Asthma, emphysema, chronic bronchitis. Also our bronchiectasis, cystic fibrosis, any tumor, aspiration, foreign object. Really just think about anything that can trap air behind it. So even when you have this baby that comes in because she swallowed a peanut, or didn't swallow but inhaled a peanut, that can cause essentially an obstructive type condition too. And so that can be their tricky way of getting you to answer these questions. Is they'll say, oh, you have some child who had a penny in their mouth and they accidentally inhaled it. Now it's in their airway. What would happen to residual volume? And you're like, whoa, what does a penny have to do with residual volume? What would that do to residual volume? And you're going to say, oh my God, you're going to be freaking out over the question. You're going to spend 10 minutes on it, and then your time's going to run out. I'm not going to let that happen to you. I'm going to sit here and tell you that foreign objects in the airway give you an obstructive pulmonary disease. So everything that you saw with COPD, emphysema, all of these air trapping disorders, they're all going to present the same way in terms of your pulmonary capacities, right? So your total lung capacity would increase, residual volume would increase, functional residual capacity. All of these things that we talked about for COPD, emphysema, they would all be the same even if you inhaled a peanut. Okay? Wonderful. Could you give me a couple examples of restrictive pulmonary diseases? Good. Wonderful. Yes. Excellent. Wegener's, yeah, excellent, very good, good. So, sarcoid, idiopathic pulmonary fibrosis, some ARDS, and chest wall abnormalities. So, if you think about a patient who, any of your like Duchenne's muscular dystrophy, where those patients can't open their lungs all the way, right? Because the muscles are dying. You think about your obese patients. This is a restrictive type disorder because they can't really open the lungs all the way. So really the diagnosis can go far and wide. Okay. Wonderful. Very good, very good. Proposed mechanism behind emphysema. I'm just going to kind of move through this quickly because we've talked about it quite a bit today. But essentially we have elastase activity unopposed by antiprotease activity. So our alpha-1 antitrypsin. Essentially, whenever we have emphysema, whether it's the alpha-1 antitrypsin type or the cigarette smoking type, we have too much activation of enzymes that break down lung tissue. In both cases, it's the same thing. Yes, one is centroacinar, one is panacinar. That's fine. But in both cases, we have too much activation of these enzymes that break down lung tissue. Okay? And in smoking, it's because of all the inflammation from the smoke. In alpha-1 antitrypsin deficiency, it's because we lack the enzyme that deactivates these other enzymes. Okay? Very straightforward. Great. Smoking, recruits leukocytes, increases the elastase. Elastase breaks down lung tissue. We get emphysema. Panacinar emphysema, you already told me that it's associated with alpha-1 antitrypsin. And great. So, last question we will do here for pulmonary. We have a premature infant begins to exhibit symptoms of NRDS, IRDS, however you want to call it. But the way that we called it earlier was NRDS, right? The neonatal respiratory distress syndrome. Shortly after birth, the lack of surfactant in his lungs is most likely causing which of the following? Take your time, look through these. I'm just going to grab a quick drink of water and then we'll come back and talk about it, okay? Okay. Okay. So, Dr. Natalia, what do you have for me? Correct. So it should have lower compliance. So surfactant is going to distribute the pressure of opening the lungs among all of the different alveoli. And so if you don't have surfactant, the lungs are not going to stretch as smoothly. And so that would be a decrease in compliance of the lungs altogether. Does that make sense? I mean, essentially, when you think about, here is one alveoli, it's connected to an airway, and here's a second alveoli. And so looking at these two alveoli, what we see is that one alveoli is big and one alveoli is small. And so if you are an air molecule, you want to go to the place of least resistance. The place of least resistance would be this nice big airspace, right? So if you're an O2 molecule, you're seeing this big airspace. You're saying, okay, I'm going to go over here in this big space because that little space is small. There's a lot of resistance there. Okay, so now another oxygen molecule comes along. And then it comes to the same place and it says, I can either go to this small place with a lot of resistance or a big place. Okay, and now another one comes and another one comes. And so next thing you know, every single oxygen molecule are all going into this same air sac. And meanwhile, this dinky little one is staying small. So this is a big, big problem because now you're going to have parts of your airways that do not expand. If you have parts of your airways that don't expand, then we would call that like a restrictive type disorder, decreased compliance, whatever word you want to use. Essentially, parts of your lung are not opening, so air can't get in. The beauty of surfactant is what it does is it is going to line this entire wall, and it's going to align the wall of the next alveoli up. And so what it's doing is it's distributing the pressure. So the high resistance and pressure here, it's going to basically distribute some of that pressure into this large one. And so when air molecules come along, there's not that choice to make. The pressure is going to be equal, whether they go north here or whether they go east into this other alveoli, the pressure's the same. And so both of these alveoli are going to expand the same amount. Okay, and so now that we have all parts of our lung expanding together, we would call that a decrease, an increase in compliance, because now it's more compliant, it's more stretchy, plenty of air can come in. Okay, so that is the job of of surfactant. The job of surfactant is to decrease compliance in the lung and to increase compliance of the lung and allow it to open more easily to air molecules coming in. Okay. But you're not off the hook, though. I still want to hear what you think about this question. So talking just about surfactant. We're not talking about the ability of oxygen to move over the wall of the alveoli into the blood supply. Okay, so surfactant is not going to play a role with diffusing capacity, right? So we can take those out, right? Good. So great. So that brings us all the way to 50%. This is what we should, any question that you are encountered with where you're just totally bewildered, find one thing that you can eliminate so that you can bring yourself to a higher percentage of getting the answer right. Okay, Natalia? Great. So now we're left with two answer choices. They both have decreased compliance, which we said, okay, that makes sense. For having no surfactant, we would have a decrease in compliance. But now we're stuck. Is the surface tension increasing in the pleura, or is the surface tension increasing at the alveoli? Wonderful. Great. So that increased tension in the alveoli means we're going to have a decreased compliance. Air is not going to go into those alveoli. This patient is going to develop neonatal distress syndrome. Okay? Great. And I really feel like, you have all the tools available for you. You can answer these questions, okay? You got this. You 100% got this. It's all going to be confidence and knowing how to break down these questions and attack them, okay? All right, great. So with that, we are going to leave this pulmonary talk behind us and move into GI. Okay, great. Save this. And okay. Okay, GI, it's a crappy subject, but it's fun to talk about, right? It's just a bit of a shitty topic, right? It's just a lot of BS. Okay, I'm trying to make jokes here, but it's okay. So great. Embryology. Let's talk about embryology. So the development of our GI tract, we really break it down to foregut, midgut, and hindgut in terms of the development wise. And then also when we talk later, the reason we break it down this way is that if we know what part of the GI tract it falls under, we know what the blood supply is going to be. What do I mean by that? Anything from the essentially from the stomach all the way through the duodenum is all going to be supplied by the celiac artery. You can see here in the diagram of our developing fetus that the celiac artery is supplying everything from the stomach here. It's going to supply the liver that's developing here off to the side. It's going to give supply to the pancreas that we can see developing right here. It's going to give supply to the spleen that would be developing on this side. Essentially everything that falls within foregut will be supplied by the celiac artery. So that helps us with the anatomy in terms of memorizing where the blood flow is going. Midgut is going to be from the second third part of the duodenum to the 2/3 of the transverse colon. And this is all going to be supplied by the SMA. So essentially all of the small intestine, the duodenum, the jejunum, and the ileum are all going to be supplied by the superior mesenteric artery. Okay, and so that's helpful. Last is our hindgut, which is the last third of our transverse colon, then our descending colon, then our sigmoid colon, then our rectum, all the way into the pectinate line is all going to be supplied by the inferior mesenteric artery. Okay, and so all of this development-wise is going to help us with our anatomy in terms of knowing what is the arterial supply, as well as what is the nerve supply. And so all of these parts of our GI tract are going to have nerves traveling to it, right? So we have our parasympathetics that will increase how much digestion we're doing and increase the peristalsis and the contracting of our different parts of the GI tract. It's also going to regulate the blood supply to our GI tract. And so the nerves that are traveling to our GI tract are going to travel along with the blood supply. So if you're asked, okay, we have a patient with a certain problem in their jejunum, what is the sympathetic nerves that are going to the jejunum? Your answer would be the superior mesenteric plexus. Because you know the superior mesenteric artery supplies the jejunum, the nerves that go to the jejunum should be the superior mesenteric nerves. And so, if you're ever asked about what are the nerves going to part of the GI tract, think about what is the artery going to that GI tract, and then give your answer that name. If you're asked about the nerves that are going to the stomach, they say, okay, so this patient has some problem in the stomach. What is the what are the nerves that go to the stomach? Your answer would be celiac plexus. Okay. Same thing for the descending colon. This patient has a problem in the descending colon. What are the nerves that go to the descending colon? You would say inferior mesenteric plexus. Okay. This is really going to be helpful in naming things down the line. Okay. And so here is a very, very wordy slide. I hate wordy slides, and so we're going to go through this pretty quickly. There are some important topics here, though, that we have to talk about. So In terms of development-wise, there are things in embryology that help us when we get to pathology. So first, we'll talk about the esophagus. So the first bit of the esophagus, it starts originally as a single tube. Can I have a pen? Thank you. So here's our single tube that is our esophagus. Eventually, this esophagus is going to break down into two different tubes. One is going to go on to connect to the stomach, and so this would be our esophagus. Okay. And then the other is going to go on to form our lungs. Okay. And so this would be our trachea. Okay. But the important thing is to know that the trachea and the esophagus, besides the fact that they are right next to each other in grown human beings like you and me, originally they started off as one single tube. And then that tube breaks off into two. And so we can start to talk about pathology here if that tube doesn't quite break into two, or if it breaks into two, but there's a connection. Okay, and so we can talk about esophageal atresia. When these ridges deviate too far dorsally and the esophagus ends as a closed tube, usually associated with a fistula between the trachea and the esophagus. And so how does this typically present? This is associated with polyhydramnios because the fetus cannot swallow amniotic fluid. That fluid is going to accumulate around the fetus and kind of smush it a little bit. So that would be our polyhydramnios. After birth, the child, as soon as the child drinks milk, because the esophagus is a blind pouch, that milk would just collect there and then the child would regurgitate it out. We're going to talk more about esophageal atresia when we get into pathology. So don't worry if that just went straight over your head. Although I'm sure you know all this stuff, we're going to talk about it more and reinforce it when we get to pathology. Okay. Congenital hiatal hernia. Here, when the esophagus does not grow far enough, it pulls the stomach. Right? So typically the esophagus is going to, let me just clear this off. So typically as the esophagus develops, it's going to go through the diaphragm. Here's our diaphragm. And then it's going to connect to the stomach, which is growing below. In congenital hiatal hernia, the esophagus is kind of short. And so our diaphragm's down here, the esophagus is too short. And so it's going to kind of pull our stomach up into the thorax where the lungs are. And the stomach is going to in turn pull a bunch of the duodenum, pull a bunch of the, maybe even some of the jejunum. Essentially, we're going to have a bunch of our GI organs inside of the thorax. Okay, some loops of small bowel, etc., etc. Typically, this is going to happen on the left side of the diaphragm. Why? Because on the right side of the diaphragm, we have the liver. Okay, and so this side is basically protected, but on the left side of the diaphragm, we can have all of these organs being pulled up and affecting that left lung. Okay? Okay, great. So the stomach typically has to go through a 90-degree rotation. During development, the stomach is not in the orientation that we're used to. During development, the stomach is basically going straight like this. And so it actually has to rotate about 90 degrees to form the stomach that we're used to seeing, where it is kind of off to the side and pointing in this direction. Okay, that's a little bit of an exaggeration, but you can see essentially it starts out vertical. Through development, it goes 90 degrees. And so this is going to give you the greater and lesser curvature. The dorsal and ventral mesenteries of the stomach become the greater and lesser ommenta. Okay, so clinically, what we can look for is hypertrophic pyloric stenosis. I'm sure you're familiar with this pyloric stenosis. This is the baby that the mom brings in about 2 or 3 weeks after birth. The baby is projectile vomiting. When she feeds the baby pukes milk up all the way across the room and it sprays the wall. And then when you do your abdominal exam, you can feel a little olive. It feels like a little bump under the skin of the baby in the abdomen, and that's because the pylorus, or this area, this muscular area of the stomach, starts to get hypertrophied and it gets bigger and bigger and bigger. And so you have this giant growth of muscle, so that whenever this baby is drinking milk, the milk accumulates in the stomach, it starts to distend the stomach, and then the baby pukes up all that milk, and then so that gives you the projectile vomiting. Okay? It's our pyloric stenosis. Continuing with things from the foregut, our liver is coming from the endoderm. Great. Pancreas is formed from two growths. Believe it or not, when your body is developing as an embryo, you have one part of your pancreas on one side of your duodenum and the other part of the pancreas on the other side. Okay. And so as your stomach is rotating and the rest of your gut is rotating, what's going to happen is this part of the pancreas is going to rotate and move around the duodenum, connect with the other side, and give us the uncinate process that we're used to seeing on a human pancreas. You usually see this little part coming down, and then the pancreas goes off like this, right? That's the pancreas you're used to. So what can go wrong? Right? So we're having this one part of the pancreas rotate all the way around to connect with the other piece. What happens if instead of rotating around, the pancreas just starts to grow in both directions and basically causes an annular pancreas, where if we look from above, here's the lumen of our duodenum, and then we just have pancreas completely surrounding our duodenum. So great. So now we get a little bit of extra pancreas. What's the problem with that? Well, what can happen is because it's all the way around the duodenum, it's actually going to constrict on the duodenum and compress this space. And so this may actually present with some obstruction, looking like pyloric stenosis without that palpable knot in the epigastric region. That's the way that you would be able to differentiate that. So annular pancreas is when the pancreas, instead of rotating around, it basically grows around the duodenum and constricts it. It's going to present with vomiting, typically non-bilious vomiting. So it shouldn't be a black vomit. It should be a light-colored vomit. And you would, so the first thing you would think of is that pyloric stenosis, but you wouldn't feel the knot on the stomach that we described earlier. Okay, and so that would be our annular pancreas. Any questions on that? No? Okay, great. So other developmental defect problems with embryology, we have problems of gastroschisis and problems of omphalocele. Omphalocele is when we have a persistence of the abdominal contents into the umbilical cord. And so we're going to see it sealed by peritoneum and present on the midline. If we look at the image here, for omphalocele, we see a bunch of gastric contents, but it's enclosed within a membrane. Okay, it's not open to the air. It is enclosed within a membrane. In addition, it's going to be right at the midline. Because it's still in the umbilical cord, it should be in the umbilicus, which hopefully is in the middle of the abdomen. I've never seen an umbilical cord or an umbilicus on the left or right. That would be kind of unusual. So it should be right in the middle. The thing that they're going to ask you questions about and expect you to know the difference between is our gastroschisis. So gastroschisis, it's going to be very similar to omphalocele. The big difference is it's not covered in peritoneum. It's just going to be open to the air. Okay, and so this is going to be just free, zero membrane here. It's just basically a bunch of loops of bowel that are exposed to the air. And this is typically going to be on the right of the umbilicus. You can see here that the umbilical cord is here, and then the intestinal loops are coming out to the right. Okay, so those are failures of lateral folds. Our caudal fold is a fold down here just above the bladder, and if that fold doesn't close sufficiently, we can have bladder exstrophy, where part of the bladder is exposed to the air. Okay, and so the repair for that is very easy. You just basically tighten up the skin above the exposed bladder and you're fine. The problem is that patients with this bladder exstrophy at birth have an increased risk of cancer of the bladder. So down the line, it's something that we need to watch out for, because if they are born like that, then they have that higher risk of cancer of the bladder. Okay. Great. So the way that I always remembered these omphalocele and gastroschisis, I used to always get them confused. I would just imagine like the omphalocele. So here's the O of omphalocele, and then the O has all of the intestinal organs inside of it, right? And so omphalocele. Okay, and that helps you remember that the O helps you remember the membrane on the outside of the organs. Next is our Meckel's diverticulum. So the Meckel's diverticulum, essentially, it's a bunch of so it's caused by the failure of the vitelline duct to involute. This is going to be the catchphrase that you'll see in your first aid book, that you'll see in the literature. Failure of the vitelline duct to involute. What does that even mean? So essentially the vitelline duct is a duct that the developing fetus uses to get a bunch of extra nutrients and everything from the mom. Okay, so this vitelline duct, it's there to make sure that the baby's getting nutrients. As the baby's developing, eventually it breaks down and disappears. If it does not break down and disappear, you're going to be stuck with something called the Meckel's diverticulum. Inside of this diverticulum, or this outpouching of the wall of the ileum, you're going to have some gastric tissue, you're going to have some pancreatic tissue. There's all different kinds of tissue in here, okay, in this diverticulum. Now, because of that, if you have a bunch of gastric tissue in this area that's not supposed to have it, you can end up having ulceration and bleeding of that area, right? Because that's a lot of acid, and that acid's going to break down tissue. And so if you ever have a patient, a young child who presents with bleeding per rectum that is not reporting any symptoms, so asymptomatic bleeding in the stool, I want you to think of Meckel's diverticulum. Okay, so that's number one. Is going to be blood per rectum, blood coming from the rectum, blood in the stool. Number one, blood per rectum in a child that is asymptomatic. Okay, so this patient's coming in, really uncomfortable. It's not so then you start to think about something else if they're uncomfortable. If they're perfectly fine, they just have blood coming out of their butt, you want to think about a Meckel's diverticulum. Okay? So now, and if that Meckel's diverticulum stays for a long time, what can happen is that it can pull part of the other GI tissue up into itself and cause an intussusception. And intussusception actually presents with bloody, mucousy stool. Okay, blood and mucus in the stool. Okay, blood and mucus. Patients with intussusception are very uncomfortable, and that discomfort comes in waves. And so the patient will be fine, and then all of a sudden they'll be screaming in pain, and then they'll go back to being fine about 10 minutes later. 20 minutes after that, they'll be screaming in pain again. And then you're having this blood and mucus every time this child uses the bathroom. Think about intussusception. What is the cause of intussusception in a young child? Meckel's diverticulum. Okay? So those are the two connections I want you to make. If you have a child that comes in with blood per rectum that is not having really any symptoms, it could be due to Meckel's diverticulum. You're just having some acid breaking down some tissue in the GI tract, causing some bleeding. Fine. If you have a patient that comes in with this recurrent severe pain in their abdomen, screaming in pain, and then going back to being completely fine 5 minutes later, and then screaming in pain again, think about intussusception. That intussusception caused by Meckel's diverticulum. Okay? So that's sort of the two ways it can present. There's this classic rule of twos, 2% of population within 2 feet of the ileocecal valve, 2 inches long, twice as common in males, and symptomatic by age 2. I'd say the most high yield things to remember is that it's within 2 feet of the ileocecal valve. And so if this is our duodenum is going to become our jejunum is going to become our ileum, and ultimately our ileum is going to open up into the cecum, which is going to go and become our ascending colon, yada, yada, yada. So most of these Meckel's diverticulum are going to be within 2 feet of this point. Okay, so if you go like within 2 feet back, if this is 2 feet back, we would typically see the diverticulum as a little outpouching at some point within 2 feet of that ileocecal valve. Okay, So if this Meckel's is presenting as intussusception, you would see that abdominal pain and bloody stool. If it is not intussusception, your patient would be asymptomatic. Okay. So what questions do you have on this? Okay. Good. If you have any questions, please stop me. Okay. Other possible developmental problems: malrotation of the gut. As our GI tract is developing, there's a normal rotation that happens. That's how we get our stomach from being vertical to horizontal. That's how we're able to fit those 30 feet of small bowel into this small space, is because of the rotation of the gut. However, if something goes wrong and it doesn't rotate in the right way, some of our small bowel can die. And so what will happen there is we're going to have ischemia and small bowel necrosis. Okay, part of our bowel is going to die. These patients are going to present with bilious vomiting during the first month. These patients typically will not have any meconium. One of the things you look for is within 48 hours of birth, babies should have their first stool. That stool will be a very, very dark, very thick stool, and we call that meconium. Okay, shortened to mec. And so if you have a patient that has this bilious vomiting within that first month and does not pass meconium, think about this malrotation of the gut causing death of some of your GI tract. Okay. Last is our duodenal atresia. And so before we talked about esophageal atresia, where the esophagus doesn't form fully and we have a little pouch. The same thing can happen on the duodenum. It is associated with, excuse me, it is associated with Down syndrome. We would see some early bilious vomiting. Your stomach will be distended. And what do we look for? Double bubble sign on x-ray. This is like bread and butter step one stuff. If you ever hear them describe a double bubble sign, duodenal atresia is the key. Why do we see a double bubble sign? Well, here's our esophagus. Here's our stomach. And here is our duodenum, okay? And we said it's atretic, and so our duodenum just ends in a pouch like that. So as this baby is eating and breathing, air is starting to come into the stomach, okay? And so it's going to start to distend the stomach. So then the air is going to go into the duodenum. And so as both of these areas get distended, what ends up happening is that, here's my esophagus again, my stomach gets very dilated, and then we have our pylorus, which is still there, and then the pylorus is kind of a narrowing, and then the part of our duodenum that is good, it gets distended, and then we have our atretic portion, and then it goes back here. And so you can see how we kind of get this double bubble. We have one bubble here, two bubbles here. Because of the pylorus is the reason that we kind of get those two bubbles. And what's happened is that this part of the duodenum is not connected to the part of the duodenum below. We have kind of a gap here where they're not connected. And so in terms of treating this patient, we would need to surgically repair and connect these two parts of bowel together. Okay. Wonderful. So we have a question here. If you want to read through this question, and then we'll talk about the answer choices together. Okay. Wonderful. Good. So, so what has happened here? I 100% agree. What has happened here? Excellent. Very good. Yes. And you can see that in the image here, right? all of these loops of bowel. And we said before that it tends to happen on the left. Why does it happen on the left and not the right? So on the right, we have something kind of protecting the diaphragm here, right? The liver, wonderful. Yes, the liver is here, and it prevents hernias from happening on the right side. We always see it on the left. That's a question I've seen. That's why I'm kind of bugging you with that, because they do ask about that. Why doesn't it happen on the right? And so you just need to know it's the liver, which you obviously do. Wonderful. And so we need to reduce the bowel, repair the diaphragm. I love it. Okay, so closure of the tracheoesophageal fistula with end-to-end anastomosis. This would be a case of our tracheoesophageal fistula we talked about, where our esophagus is ending in a pouch. Our trachea, which is right next to the esophagus, is going to have a fistula that forms that ultimately connects with the distal part of the esophagus. This is tracheoesophageal fistula. What I just drew for you, that is tracheoesophageal fistula. So when this baby drinks milk, the milk goes into this atretic esophagus, and the baby is just going to puke it right out. Okay, from birth, that baby is going to be puking it out. And so what we need to do here is to repair, we need to close this fistula and then connect this esophagus, these two parts of the esophagus together. Okay, great. Decompression via thoracocentesis. This would be if we had some kind of pneumothorax, where we have a collection of air in the pleura. We don't have that here, so we can take that one out. Left total pneumonectomy. Do we want to take out the left lung? Probably not. So we'll take that one out too. Thoracotomy with partial lobectomy of the left lower lung. No, that doesn't sound good either. So great. Excellent. And you picked it right off the bat. Very good. Any questions on this question? Anything that didn't make sense from the question stem? No? What do you think of these ABG levels? PaCO2 of 56 and PaO2 of 39. Mm-hmm. Yeah. Very good. Very good. Excellent. Awesome. Okay. And so the last thing that I will ask you, because I know this is a subject that a lot of people absolutely hate. So what is this newborn baby's pH status? Is this a respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis? What do you think? What would be your assessment here? And there can be multiple things happening. We haven't talked about this together, right? Natalia, we have not talked about all of these different things together. So our normal pH, I'll tell you our normal pH, and then you can tell me whether it's acidotic or alkalotic, right? So our normal pH is anything from 7.35 to 7.45. That's our normal pH. So for this patient, is this patient acidotic or alkalotic? Acidotic. Awesome. Good. So we have an acidosis, and we have a PaCO2 of 56. Super high. So that is definitely going to be respiratory. Okay. And sort of adding into that, not helping at all, is this lactate level. So lactate actually is an acid, and because we're having the destruction of a lot of our lung tissue here, probably some of our GI tissue here is dying too, on top of our respiratory acidosis, there's probably a metabolic acidosis as well. We have two things working together to really make this patient acidic, okay? And so it's kind of a double whammy, not good. And don't worry, we'll do plenty of acid and base questions later, okay? But very good, very good. So anatomy and physiology. In terms of the blood supply and innervation, what I told you before is going to apply here. For our foregut, anything from the stomach all the way through the second part of the duodenum will be supplied by the celiac artery. Parasympathetics are coming from the vagus, and the sympathetics are going to be coming from the celiac plexus. Okay. Midgut is artery supply is SMA. Midgut is everything from the second part of the duodenum to 2/3 of the transverse colon. Parasympathetics are going to be the vagus, and the sympathetics are the superior mesenteric plexus. All right. For the hindgut, we have the IMA providing blood supply, and our pelvic is going to be the source of the parasympathetics. Sympathetics will be coming from the inferior mesenteric plexus. Okay. And so that's great. Now, sort of looking at our entire GI tract, it's a really beautiful structure. Something that I would like to point out here is this splenic flexure of the transverse colon. This is an especially important place in our GI tract, because this is the place where if your patient becomes hypovolemic or has a low supply of blood, this is the place of your GI tract that tends to be affected first, okay? It's called a watershed area. I'm sure you've heard this before, right? Watershed area. And so what that means is that instead of getting a nice blood supply from the superior mesenteric artery or getting nice blood supply from the inferior mesenteric artery, it kind of gets weak supply from both, okay? And so if you ever have some sort of situation where your patient has very low blood supply in their body, say they have some sort of hemorrhage, or that they're really bleeding out, they're losing blood, this is going to be the area of your GI tract that's going to be affected first, is that splenic flexure of the transverse colon. Okay, very important location. In terms of questions, they love asking about that. All right. And so another thing that they may ask about are the different ligaments. The most important ligament that you need to know about is going to be this hepatoduodenal ligament, the ligament that goes from this part of the duodenum all the way up to the liver, right? Hepatoduodenal, going from the liver to the duodenum. Why do we need to know about this ligament? Because inside of this ligament, you can see that there's three very important structures that we call the portal triad. Okay, so what are the structures of the portal triad? What are these three structures? I see an artery, I see a vein, and I see this green thing. What are those three things? Yes, common bile duct. Very good. So for the vein, right? This is a vein carrying blood from the GI tract to the liver. What would we call that? I would tell you, but you're gonna hate me for telling you because you know this one. So this one is going to be the portal vein. Right, the portal system is the system that carries all of our blood supply from our GI tract to the liver. It allows for detoxification, absorption of nutrients, all that good stuff. The portal vein is responsible for that. It's a very, very big vein. It's a very big vein and very important. Okay, so we've located that. And then what about this artery? What is the artery that branches from the celiac trunk and goes to the liver? Don't know, that's okay. That's our proper hepatic artery. Okay, so those are our three structures: common bile duct, portal vein, and our proper hepatic artery. So the proper hepatic is bringing blood supply to the liver and also to the gallbladder, and it is a branch of the celiac trunk. Okay, and so This is important because surgically, these are the structures we want to identify. If we're doing some sort of surgery, maybe taking out the gallbladder, we want to make sure that we don't injure any of these structures. And so we really want to identify those, very important. And so the way that we identify them is we look for this ligament, the hepatoduodenal ligament, and that shows us that, okay, let's not go towards this area. Okay. There's a lot of other ligaments. You don't need to know those, okay? Not important for step 1. This is the one that you really need to know, and know what's inside of it, okay? Great. And so just sort of talking about some of the branches of our abdominal aorta. For step 1, the important thing to know is, where are these branches in terms of your spinal level, right? And so the first branch that's going to come off is our celiac trunk. This is going to be giving all of our blood to our stomach, pancreas, spleen, liver, gallbladder, and part of our duodenum. I don't know if I mentioned duodenum already, but celiac trunk, very important, has 3 branches. And so that is going to be branching at about the area of T12. At the level of L1, L2 is where so at the level of L1, we see the superior mesenteric. At the level of L2 is where we see our renal arteries. Level of L3, we see our inferior mesenteric. And the abdominal aorta is going to branch into the common iliacs at the level of L4. The way that we remember that is bifurcation, right? Bifurcates, it bifurcates at L4. Pretty straightforward. By the way, this is a very beautiful diagram from the first aid book that definitely helped me memorize where some of these branches are happening. If you're to be asked about it, just remember that everything starts at T12, right? While we are in the abdomen makes you think of lumbar. Everything's starting at T12, and we're going to go from that level. So in terms of the branches of our celiac trunk, the first branch of the celiac trunk is going to be our left gastric artery. Left gastric artery really just has one job to do, and that's to provide blood supply to this to the smaller part of the stomach. The lesser curvature was the word I was looking for, not small part. So the first branch of the celiac trunk is our left gastric artery. The second branch is going to be our common hepatic artery. The common hepatic will immediately branch to give us our gastroduodenal, and then the other branch will go to the liver as the proper hepatic. This is within that hepatoduodenal ligament we just talked about. And then it's going to branch into our left hepatic, our right hepatic, and our cystic to go to our gallbladder. Okay. The third branch of our celiac trunk is going to be this splenic artery traversing the back and ultimately ending at the spleen, which would be over here doing whatever the heck the spleen does. Nobody really knows. As the splenic artery is going towards the spleen, it's going to be perfusing the pancreas, which is located right behind the stomach. And so we're going to have these little branches going from the splenic artery into the pancreas. Okay. Our gastroduodenal, we mentioned before, is this first branch of our common hepatic. The gastroduodenal is going to give a branch that becomes the right gastroomental for the greater curvature of the stomach. And it's also going to give a branch to the pancreas and duodenum as the pancreatico-duodenal artery. Okay. The last branch that we need to mention is this. So the splenic artery is going to give a branch to the greater curvature so we can have an anastomosis or a connection between these two arteries. And it's also going to give the short gastric artery that gives blood supply to the fundus of our stomach. Okay. And that is it. That is all the branches of the celiac trunk that you need to know. Any questions on this? A lot of memorization, right? Yeah. But really, the nice thing about this is that things are named for where they're going. So in terms of the stomach, you have your left and right gastric for that lesser omentum, left and right gastromental for the greater omentum. The common hepatic branches, you get a proper hepatic that goes to the liver. Hepatic means liver. So, a lot of these, the name is just going to go with where it's going, and then all it comes down to is memorizing where they all branch. I think I would recommend, in terms of memorizing this stuff, is just to somehow cover all of these up with boxes. If you have this PDF, you can just draw in little boxes and then try and fill in as many as you can. Do that 3 or 4 times. If you can't get every single one of them, that's okay. Try and get a majority of them so that on test day, if you're given a diagram to label, you're going to feel comfortable with knowing in general where these different arteries are. Okay, but I don't expect you to be able to draw this from memory. Okay. So moving down into our superior mesenteric artery. So our superior mesenteric artery is going to give a few important branches. Our ileocolic artery is going to be a branch of the superior mesenteric. Right colic artery for our ascending part of the colon. And our middle colic artery for 2/3 of the transverse colon. Okay, so everything from this, the ileum, the cecum, all this area is going to be supplied by the superior mesenteric artery. Okay. Moving into the inferior mesenteric artery, you can see we have a branch that goes to the left colic, which would be our descending colon. We have the sigmoid arteries, which go to the sigmoid part of our colon here. And then we have some rectal arteries, which supply the superior part of our rectum. Okay. There are also, obviously, branches of the superior mesenteric artery which supply our small bowel. So, from our duodenum to the jejunum to the ileum, all of the blood supply for the small bowel is going to come from the superior mesenteric artery. Okay, and so that's not shown on this particular image, but just something to know and to keep in mind. In terms of our venous return, there's a couple things that I want to point out. This is not a diagram that you need to be able to label from memory, and I'll say that about this one too. Not as important to know these branches as it is to know the branches of the celiac artery, but there are some important things with the venous supply that you need to know. So the first thing is that, and this is sort of what we touched on earlier, that for venous supply, you have 2 systems. You have the systemic venous supply, where it's all of the deoxygenated blood coming from the lower extremities, from the skin. All of this stuff is going to go through the systemic supply, and it's going to join up here at the inferior vena cava. Okay, and it's just going to go straight back to the right side of the heart. Any blood supply coming from the GI tract, from the stomach, small bowel, large bowel, all of that blood needs to be detoxified. Evolutionarily, you think about our, great ancestors running around in the woods, eating whatever they could. Some of that stuff that they would eat would be toxic. Okay, and so our bodies developed in such a way that anything that we eat has to go to the liver first before it goes to systemic supply. So that our ancestors, when they ate that toxic berry and it went into our GI tract, and then we absorbed that toxin into our bloodstream, that toxin wouldn't go straight to the heart and then straight to the brain and kill us. Instead, that toxin goes into the portal venous supply, and then it goes via the portal vein to the liver, where the liver can have a chance to detoxify that toxin and prevent us from dying from a blueberry, which is not a very cool way to die, right? And so this is the first thing that you need to know. We have a dual system. The systemic venous system is carrying all of the blood from our extremities, from our skin, all of these vital organs, our muscles. And then the portal supply is carrying all of the deoxygenated blood from our GI tract to the liver so it can be detoxified. Okay, so that's point number 1. Point number 2 is that there are areas where these 2 systems connect. Okay, and we call those systems essentially an anastomosis, where we have our systemic supply joining our portal supply. And so if we look here, what better place to look but at the rectum, right? Let's have a good look at this rectum. What you can see is that for the most of the rectum, all of the venous supply is going into our portal supply. So here we can see a superior rectal vein carrying all of this blood supply to the rectum into the portal supply. Oh, that's okay, God bless you. Into our portal supply, which will ultimately go into our portal vein and to the liver. Okay. Now, in the lower part of our rectum, what you see is the venous supply, instead of going to the portal vein, it's going to our systemic supply. And so it's going to go through these iliac veins into our inferior vena cava and go straight to the right heart. Okay? So there are certain areas where these two systems connect. And this is important because when we start to talk about cirrhosis, cirrhosis is going to increase the pressure in our portal supply. If pressure is going to increase here, then blood, instead of going up into our portal system, blood instead is going to travel down into our systemic system and try and get back to the heart that way because the pressure is too high here in the portal system. That is ultimately going to result in hemorrhoids, right? And we're going to have varices because of this fact. So when we talk about our hemorrhoids, when we talk about our esophageal varices, when we talk about our caput medusae in the abdomen, which are essentially umbilical varices, the reason we have all of these is because there are certain areas where the systemic and the portal systems can connect to one another. Okay? Questions on that? No questions. Okay. We will talk more about that as we get into our, talking about pathology, talking about all these varices and what we can see in terms of our patients. We'll go through gallbladder, the acinus in our liver, the inguinal canal, inguinal hernias, our retroperitoneal structures, some of the physiology of our stomach, and all the different hormones that function to keep our systems working, biliary systems, bilirubin, and then we'll go through some questions. Okay, we don't have too much left on this lecture, and so we're going to leave a little bit for post-Christmas, okay?